I'm a genetic counselor within the Division of Human Genetics at the National Health Laboratory Service and the University of the Witwatersrand in Johannesburg, South Africa. And I'd like to welcome everybody to the second PUBGEM-Africa Science and Society Café on genomics, data science, and health research. PUBGEM-Africa, which stands for Public Understanding of Big Data in Genomics Medicine in Africa, is a bioethics project within the Data Science for Health Discovery and Innovation in Africa, DSI Africa Consortium, and is funded by the US National Institutes of Health. We specifically acknowledge the support of the National Human Genome Research Institute and the National Institute of Mental Health. So today's cafe is on the topic of rare diseases, genetic literacy, data science, ethics, and sociocultural perspectives. And I thank you all for making the time to come to this Science and Society Cafe. So it's a Harambee Society and Science and Society Cafe, which is a Swahili word, which means let us work together for the common good. So we therefore hope that these cafes will be a platform for all of us, irrespective of our disciplinary backgrounds and expertise, to work together to ensure that the use of genetics and data science in medicine and health research is done in a way that is ethical and considerate of our diverse sociocultural values and belief systems. So the goal is to have a conversation on community engagement strategies that may be effective and acceptable for genomics and data science for health and innovation in Africa. So during this cafe, we encourage you to use the Q&A box, which some people have already used. So I'm glad some people have found it already, to share your views on the topic and to ask questions about the panelists. We'll also give some time for oral contributions from attendees. So please raise your hand if you'd like to speak. And if you feel like you're not being attended to for whatever reason, just send a message in the box and we will definitely try and reach out to everybody. Hopefully we can have a very engaging discussion and something that's really important for now and for years to come. So our order of speakers, we're going to start off with Prof. Lukama, who is a pediatrician and professor of genetics at the University of Kinshasa in the DRC of Congo. And he is a principal investigator on the African Rare Disease Initiative. He is the director of the Reference Center for Human Rare and Undiagnosed Diseases in the RD Congo, and the coordinator of the Genomic Medicine Platform at the University of Liège in Belgium. His work focuses on the use of NGS in the diagnostic and research of rare diseases, as well as in care improvement for rare disease patients, especially the critically ill children. He's engaged in increasing accessibility to NGS for rare disease patients from underserved communities. And Dr. Lukama will speak on his experience addressing ethical considerations for rare disease diagnosis and research in Africa and strategies he uses for stakeholder engagement. So we're very excited to hear. Thank you very much, Dr. Lukama. You can share your slides.
Thank you very much, Monica, for the kind introduction, and thank you for to the project and the organizers for inviting me. I don't have particular slides to present because this will be a conversation, and we want this to be the more engaging as possible. But I will just give a brief introduction of the concept we are talking about today, which is this concept of rare diseases, what it is about. I only have a couple of slides on that. So this is where we are working, and we are located, the Center for Human Genetics at the University of Kinshasa. It's the umbrella organization where the Reference Center for Rare and Undiagnosed Diseases is located, and it's also home for the African Rare Diseases Initiative. You can visit our website. We are the website of the African Rare Diseases Working Group. I'm going to type that in the chat for everybody to click on and to visit. So our main focus is rare diseases. And disease is defined as rare when it affects less than 1 in 2,000 individuals, according to the definition by the European Union. And this has become the most widely used definition when we are talking about rare diseases. And taken together, even though each of those diseases might be rare, it is actually estimated that about 3.5 to roughly about 6% of the population of the world is actually affected by a rare disease. So this is a number that shouldn't be neglected. When we look at the registries of rare diseases, how many diseases are actually within this register? It varies depending on the ORPHANET, that is the European version of the NIH, or the NIH version. The NIH registry actually counts about 7,000 different individual diseases that are recognized as rare diseases. For the USA, it is estimated that 25 to 30 million of people are affected by a rare disease. To put that into perspective, it means that 1 in 10 Americans is affected by a rare disease. 4 people in any bus riding in the USA, 4 people have a rare disease, have any of these 7,000 rare diseases. And if you are taking an elevator in the US, you are certainly standing next to someone who has a rare disease. So we also know that about 2% of those diseases, they have a genetic underlying cause. About 70% of those diseases actually manifest during the pediatric age, which means that they would actually contribute to the death of patients when they are infants or they are children, or they would actually cause consequences that would actually become more severe over the age and prevent those children from contributing to the economic of the society. We also need to acknowledge that the distribution of those diseases is not even in the world. Some diseases are more frequent among the Caucasian descent population. Other diseases are more common in African descent population. In this example, you would see, for instance, sickle cell anemia that is very frequent in Africa is almost non-existing in some part of the world. And you will also see that phenylketonuria, for instance, is highly common in the population of the Jewish Ashkenaz descent, which means that for us to properly serve the African community, we need to get a better understanding of the problem that we are facing, which diseases that we encounter, and how can we use this knowledge to help the community. How can we advance the genomic medicine for rare diseases? Any advancement is only possible when we have knowledge. So that's why really it's important to talk about that in this particular the café today, is because we need data. When we have data, we can compile this data to extract the information. When we extract the information, that becomes the knowledge. And from the knowledge we have, we then know how we can implement this into measures to change the health of the population. Let me give you a practical example of this. We need to talk to parents and ask questions or create confidence in a way that they will be comfortable sharing with us the daily life of their children. When we get accurate information from parents, when they are comfortable enough to share information with us, we can actually collect this information that could be the height of the children, the weight of the children, that could be the BMI of those children. We can actually collect information on the diet of those patients. Parents can actually easily share the diet their children are receiving on a daily basis. They can actually share medical information, how many times they have been sick or hospitalized. That can be actually summarized into information, meaning what is the average height of children of this particular region? What is the average weight? And what is the average number of calories they are receiving? When we have this information, now we can generate knowledge. What is the link between the height and the diet regimen? What is the link between the weight and the number of time children have access to food in this community? And then we can translate this into measure. Okay, we have observed that the height of those the children in this community is it's really low. It means that they have a growth problem. We have also observed that it's more associated with the number of time they are receiving food, or it's more associated with the food content they are receiving. Then we can translate this into measure, teaching parents how to grow food, develop a garden in the backyard so that they can have additional food to improve their health. So it all starts with collecting data, and collecting data starts with creating the confidence between those who are doing research or the medical community with the parents. Without that stage, we would not be able to impulse the change that is needed for any health sector, and especially for rare diseases. So this is what I wanted to start, and I hope we can have an engaging discussion during this cafe. Thank you, Monica, back to you.
Thank you very much. I wanted to find out, Nchangwi, did you want us to do some questions in between, or would it be better for the panelists to all speak first?
I think it will be great if we have the panelists speak first and we have a discussion at the end.
Okay, so if you have any questions for Prof, please make sure that you note them so that we can get back to him and ask him all the burning questions. I have a few and I'm going to write them down so I don't forget. Okay, next up we have, let me get to the right page. We have Dr. Yalkunye from, who obtained his MD degree in neurology and a PhD in human genomics from the University of Sciences, Techniques and Technologies in Bamako, Mali, and the University of Cape Town, South Africa, respectively. He is currently a postdoc fellow at the Johns Hopkins University School of Medicine in the USA. His research focuses on the genetic studies of congenital hearing impairment and inherited peripheral neuropathies in the African populations. Dr. Yalkunye is a member of several scientific societies, including the African and American Societies of Human Genetics and the Peripheral Nerve Society. He will speak about ethical considerations and community engagement approaches for his research on Charcot-Marie tooth disease and other neurodevelopmental diseases in Africa. There we go.
All right, thank you so much, Monica. Hopefully you can see my screen.
We can.
Great. Thank you so much for having me in this cafe discussion. I will be using 2 case studies to highlight this discussion. I'm happy that Prof. Emil Lumaka had already given the epidemiological aspect of rare disease research in Africa. Using these case studies, I will draw practical lessons we have learned from this research on Charcot-Marie disease. So the first case I'm going to discuss is a family, a patient we have seen in clinic, a 45 years old male who was seen initially in April 2016, and his chief complaint was walking difficulty that started at the age of 8, meaning that he has stayed with the disease progression for more than 30 years. And the family history have shown that several members of the family presented similar symptoms. And as I will be showing some images of the patient, he was seriously disabled, as many members of the family. So this is the family structure on the pedigree, the proband, his uncles, and many individuals affected in the family, including male and female, as you can see in this pedigree at different generations, which is highly suggestive of autosomal dominant transmission. So these are the images of 3 different individuals we have seen in the same family. This is the proband, who is, as you can see clearly, with muscle weakness in the upper limbs, but it's a very similar muscle weakness in the lower limbs too. The second in the middle, as you can see here, this patient was 18 years old, and he was wheelchair-bound at the age of 25. And the third one, who was the most disabled individual in the family, as you can see in this images, this is the position he's able to stay during since he has been in this position for more than 10 years. So the only thing, even for eating food or things like that, he is not able to use the hands or the feet because of these conditions. Initially, we suspected peripheral neuropathies, and we decided to do the panel gene testing. This time, the panel gene testing included 58 genes plus the mitochondrial genes. And the panel testing revealed that 2 compound heterozygous variants were identified in the gene called periaxin, and the periaxin gene was already known to cause autosomal recessive Charcot-Marie-Tooth disease. And these informations were not conclusive based on the pathogenicity of the variant with the unknown significance, and also the inheritance pattern through the pedigree, which is clearly autosomal dominant. Then we decided in 2019 to send the sample for whole exome sequencing using trios and affected and unaffected individuals, in which we identified autosomal dominant heterozygous variant in the gene called cadmin3. And at that time, this gene was not identified because the gene was identified in 2023. And we finally made the diagnosis of CMT2FF caused by the cadmin3 gene. And this gene was identified in Caucasian families, about 5 families having the same variant in the same gene. Through the international collaboration with CMT experts, we were able to assess this variant using cell models, which definitely confirmed that the variant was pathogenic. And when we're ready to publish the case, because of these collaborations, our collaborator at the University of Miami, Prof. Stefan Zuckner, connected us to someone else in the US, also having a Caucasian family with the same variant as we identified in Mali, but this variant were not reported in public SNP database, including ClinVar or NOMAD. So we published this case in 2023. The second case I'm going to mention is that this one will be very brief. It's also a family with obviously dominant trait, but X-linked dominant. And the proband was also seen for working difficulties, who ran for at least 10 years. And the proband of this family is actually the president of the Rare Disease Association in Mali. So since we established the molecular diagnosis of his conditions, And with the leadership of Prof. Gida Landoure, the Rare Disease Association in Mali was established, and this patient is actually now the one who is leading these associations. So from these two case studies, we were able to learn some few lessons. In terms of diagnostic challenges in Africa, actually one of the barriers that make the research in the rare disease Africa difficult is the traditional and cultural belief barrier, because rare diseases or undiagnosed diseases are thought to be mystic or are caused by ancestry, spirit, or supernatural. And it's sometimes challenging to convince individuals or the community that this is caused by genetic variant or genetic variations. The second reason is the genetic discrimination. Because of the way our society are structured, I believe is common in most African countries, but for the specific case of Mali, I know that if it's known that this particular family has this type of conditions, even for marriages and other societies, activities is really, really stigmatizing for those individuals in the family. So, and also the psychological impact is less considered in those families, and the social isolation and the stigma is really, really important. And the second level of challenges I can mention is the lack of awareness among even the healthcare professional. Like for the disease like Charcot-Marie-Tooth disease, it's really uncommon to see a practitioner able to recognize Charcot-Marie-Tooth disease symptomatology or identify the cause of this kind of diseases. But it's the same thing in many other neurological diseases, including ataxia or Duchenne muscular dystrophies and any other hereditary conditions. And the third level of challenges in terms of diagnosis is actually the limited access to diagnosis tool. Although the NGS, the cost of sequencing has drastically dropped, but compared to simple testing like for malaria and any other communicable disease in our context, it still be very expensive. And the last row of challenges I can mention is that because of the lack of specialized reference center across the continent, it's really difficult for people, even for healthcare professionals to, even if they think about the specific diseases to be in touch or to discuss the case with experts. But if we have like regional reference center, I know that Prof. Emil Lumaka has similar approaches he was talking about, and this kind of initiative will be really appreciated to shift from these challenges to make the diagnostic more appropriate and accessible. And let's talk now a little bit about the access to care for rare diseases. Although in our healthcare infrastructures are highly limited in most African countries, particularly in Sub-Saharan Africa, but most of these rare diseases and undiagnosed are caused by genetic variant in about 80%. Prof. Amy just mentioned it. And most of them do not have curative treatment. And this is really, really a big challenge. And we possibly need government and international partnership to push ahead the access to treatment for rare diseases across the continent. And then we also need to invest in research to identify if the existing treatment for some of those conditions are appropriate for African patients, and if there's any specificity of these phenotypes of those diseases in African patients. And also, we need to build capacity, investing in African scientists, research in genetics and rare diseases. I know the initiative like H3 Africa have trained, invest a lot in terms of training of young scientists. I'm part of this initiative. And also, we need to promote collaborations. International partnerships are really welcome, but we need to strengthen our collaboration within African researchers, particularly those involved in rare diseases. And also, we need to build some data sharing platforms and biobank to trustfully share and collaborate within African scientists. So some of the social implication is that, as I earlier mentioned, that the genetic discrimination make that even if some of this patient or family are willing to understand what is this disease, what is causing this disease, but they are afraid of the the public disclosure of this kind of genetic information within the family. And also the psychological impact is really less access, and then the mental health resources and support systems should be improved to make those families and individuals to feel free to consult, and then feel free to understand that even healthcare professionals are highly supportive of these patients. Lastly, is one of the most important things we have learned in terms of community engagement activities is the creation of the Rare Disease Association in Mali, and is one of the patients who is leading this association. And we take opportunity of the Rare Disease International Day to celebrate rare diseases, where we invite individuals with rare diseases, and we give the opportunity to those patients to talk about the disease they experience, what they have been facing within the community. And we also, as scientific, we talk about these diseases and give them the scientific background and the cause of this disease. This kind of approach is really help them to understand that this disease is caused by this particular variant, this particular gene, but it's not caused by any mystic or any supernatural forces. In terms of ethical implication, I think for the general population with low literacy in terms of, not talking about genetic even, but I'm talking about generally low literacy people, it's really sometimes difficult to make them understand some, genetic terms, information they really need to make their decisions. One of the examples I've seen in clinic, I remember that we have seen a patient a while ago, 2 or 3 years later, he's still, he was consulting other physicians, trying to understand what was going on with his phenotype and within the family. But somebody gave him my phone number. He tried to call me without knowing that I was the one who even recruited the patient in the clinic. When he came to the clinic, and then when he saw me, I said that we know each other, right? we are busy investigating the case of your family. The patient was a bit surprised that he started the investigation at this clinic, and then he spent several years, and after someone said, oh, go to this center, they are the specialized person, they are the one who can identify the cause of the disease, they can help you. So this is just to say that the initial work we did, we believe that the patient understood all the information we have given for them to make the decision to get involved in genetic research, but we realized that this was maybe they did not understand, or maybe because they didn't get any kind of information they wanted to hear. So these are really challenging in the African context, particularly in Mali. And some of the unforeseen outcome or secondary findings, like forced paternity or maternity, or potential risk predicted by a particular variant, this kind of discussion is really difficult. And we should be careful about discussing or disclosing this kind of information in our research settings. And lastly, as I mentioned, the genetic testing costs are really dropped, but because most of these diseases, they don't have any curative treatment, it's difficult for clinicians to convince people that this is caused by this kind of variant, because it's very easy to tell people that this is, like, if you are in the scenario of having a patient suffering from malaria, the test is very simple, it's not expensive, and then patient can take the drugs for a few days, and then everything is okay. But in the context of rare disease and undiagnosed, that's caused by a genetic variant, it's really difficult, because you don't have any, I won't say you don't have any evidence, but you have the evidence, but convince the people that this is a disease that do not have any treatment can be also challenging sometimes. My suggestion in terms of priorities and perspectives is that, as I earlier mentioned, that we definitely need to go for the creation of regional excellence center for rare diseases. We also strengthen our collaboration within African researchers. We need to collaborate with rare diseases experts internationally, and we also need to build biobank and data sharing platform among African researchers on rare diseases. And at the level of national or regional, we definitely need to establish some registry of rare diseases, and ultimately we need to invest in young researchers to get them involved in rare disease research to become expert in disease specific. And lastly, we definitely need to involve patient and the community in the decision-making process. When we talk about diagnosis, when we talk about treatment, when we talk about research on rare diseases across the continent. So that's all. I think I'll be happy to participate in the discussion if you have any questions around what I just mentioned. Thank you.
Thank you so much. I think you raised a lot of really important things and a good starting point for some discussion, particularly around community engagement and combating those traditional belief systems, because I think that although you mentioned that it's very common in Mali, we know that it's common in many African countries, and it's a sort of barrier to accessing a lot of things. So yeah, definitely. Thank you so much. I'm going to introduce our next speaker. So our third speaker is Dr. Kamga Karen, who is a Cameroonian medical doctor whose passion for genetics started more than 10 years ago, when as a medical student, he worked on etiologies of developmental delay in children between 3 and 72 months for his final dissertation. For the following 5 years, he then worked as a general practitioner in a semi-urban setting before moving to the prestigious University of Cape Town to complete his PhD in genetic counseling. He's currently a postdoctoral researcher in medicine at the University of Cape Town and works as a genetic counselor at the Limbe Regional Hospital in Cameroon. Dr. Karen will talk about the common ethical and societal implications he has experienced in the provision of genetic services, either as part of healthcare or research for Fragile X syndrome. So thank you so much, Dr. Karen. You are welcome to share your slides.
Thank you very much, Monica, for giving me the time to speak. To begin this presentation, since it is an open conversation that we'll be having, I'll be a little bit short because Professor Lumaka and Abdullahi had already said so many things concerning what I was supposed to say. So, to define rare diseases, there's no specific definition for rare diseases, but as Professor Lumaka said, a rare disease is a group of heterogeneous disorder that can affect 1 in 2,000 population. And we have to note that most of the rare diseases affect primarily pediatric population, and we have about 72% of rare diseases that have genetic origins. Concerning the diagnostic odyssey of patients, when we have, for example, a patient who presents with the first, when a patient first has his or her symptoms, he's going to visit a primary care physician, and maybe he may not have any solution after visiting a primary healthcare physician. Then he may go online and start searching to see if he can have any other information about the disease. Then he can fall on a specialist who can give him a diagnosis or no diagnosis. Then the patient and the relative will be stuck in some sort of circle where they don't have anything, they don't have any diagnosis, any diagnostic closure for their disease. And due to that, they may rely on other alternative medical practices like traditional medicine in order to cope with their condition, up till the point where they may reach at the level where they join an association who can then offer them genetic testing. Then after the genetic testing, they may have a diagnosis or not, and they can actually be referred to specific disease group after after a diagnosis have been offered. For this, I'm going to be talking about Fragile X syndrome in Cameroon, which is a research study that we conducted in Cameroon. We said that Fragile X syndrome is a genetic condition which is characterized by intellectual disability and behavioral changes. And this is due to a particular mutation on a gene that is called fragile FMR1 gene. And this gene is responsible for the production of protein, which is very important for brain development. Concerning the prevalence of Fragile X syndrome, the exact prevalence is not known, but from data obtained from the US and other non-African countries, we can estimate the prevalence to be between 1 in 4,000 to 1 in 8,000, meaning that very little research is being done in the African setting concerning rare diseases. So in Cameroon, we had a mother who brought her 2 children for consultation because they were intellectually disabled. And in this mother's family, there was a history of curse. And this curse was that the grandfather of the mother actually cursed the daughters that they are going to give birth to intellectually disabled children. This mother did not accept this curse explanation that she was given in the village. So she sought for medical expertise in order to have another explanation to what is wrong with her children. So she came and met us at the hospital, where at that point, Professor Gefak and Professor Ambrose offered them genetic testing. And at the end of the day, we realized that the 2 children were suffering from Fragile X syndrome. And this gave some sort of diagnostic closure to this family. So after this, we interacted with her community for more than 2 years in order to understand what was actually going on in this community. After our interaction and with the collaboration with other African facilities, we could offer genetic diagnosis to this rural community. These are just pictures to show our different interactions within the community. So after offering the diagnosis to this community, we then drew a pedigree to actually show how the trend was flowing into the family. Receiving a diagnosis actually brings some sort of relief and diagnostic closure to the different participants. And this is what one of the participants said. When I came out that day, the day that she was given the result, my husband thought that it was a war that they had told me, but I was singing and dancing all over the hospital. And even on the road, I was singing songs of praise. I was just singing and dancing. So you see how happy a parent can be when the parent has a diagnosis for a rare condition that they have been going on and on looking for solutions to their problems. Some of the challenges that we can have with rare diseases in Africa, as Abdullah mentioned, we have our different cultures where we usually believe that everything that happens to us must have a traditional explanation or occurs, just like in our case. Also, Abdullah mentioned the limited knowledge and training of health personnel about rare diseases. Moreover, due to the rarity of these rare diseases, it is a little bit difficult to have treatment for many of the rare disease conditions. So to address these rare genetic diseases, we think that organizing education and awareness campaign in the different in communities, we are going to help to educate them about rare genetic diseases. So in Cameroon, we have come across an association that is actually helping people with rare genetic condition, and the association's name is Genetics and Ethics for Cameroon Population. In this association, we have people with rare disease condition where we use our medical expertise in order to help them explain to them what actually they are suffering from. And we think that if we multiply such initiative all over Africa, we are going to have a better understanding of rare conditions in our society. Well, I think I will stop there, and I will be happy to receive questions.
Thank you so much. I'm excited for the questions that are coming, because this has been a great setting the scene of what's happening in Africa. Lastly, we have Kelly. So Kelly Duplessis is a wife and mother of 2 children. She is also the CEO and founder of Rare Diseases South Africa, which is a registered NPO. So Rare Diseases South Africa was born out of necessity when her oldest child, Juan, was diagnosed with Pompe disease, a rare neuromuscular disorder, at 11 months old. At the time, treatment for this rare condition was not available in South Africa, and so Kelly's personal journey of patient advocacy started. Having dedicated her life and career to furthering the plight of those impacted by rare diseases in developing countries, Kelly serves on various boards and committees which focus on improving the quality of life for rare disease patients, and has ensured that patients' voices are not forgotten. Kelly was awarded the African Leadership Award for Healthcare and is the winner of the Best Patient-Led Health Advocacy Group by Healthcare and Pharmaceutical Awards. Kelly will present on the challenges faced in diagnosing, treating, and effective strategies for public discourse and engagement on rare diseases in Africa. So over to you, Kelly.
Thank you so much. I just want to check that it is coming through.
Yes, thank you.
All right. So thanks so much. Really, really interesting discussions, and I think hard acts to follow, and a lot of what I'm intending to say has already been said. But, you know, this whole discussion is around data, engagements, connections, reducing the diagnostic odyssey, et cetera, et cetera. And I think that there's some really pertinent points, if for nothing else, that we can learn from the rare disease community and how we've had to do things because of the, you know, the nature of our space. So I'm hoping that this is coming through. So in the South African space, we've got 1 in 15 South Africans impacted by a rare disease. And I think it was the first speaker that said, you know, if it's not you, then it's probably someone around you. And that rings really, really true. I think we have an issue in that the perception of rare diseases is that they're so rare that you're never going to see them, that you won't account for them anywhere, and that they certainly don't need to be a priority, which couldn't be further from the truth. I think we continue to have a lot of challenges which are still relevant across the continent. we have a low priority in national health systems. We have these conditions that are often chronic and progressive and debilitating, and that there is still such a big diagnostic odyssey, averaging 7.2 years for a patient. We still sit in issues where we have a lack of access to reliable information, limited treatment options, isolation and stigma, financial and social burden, and high burden of care for family members. And, you know, I just want to speak about the isolation and stigma. I was at a meeting recently speaking to someone from Tanzania. In Tanzania, they report issues around albinism, etc., when it comes to stigma. And they still had 904 people murdered with albinism year before last. And it just absolutely blew my mind that in this day and age, that is still the level of stigma that many patients with rare conditions are facing. So understanding the needs, and, you know, this is a little bit of a question, I suppose, for the audience. You know, how many of you battle with chronic conditions such as hypertension, asthma, heart disease? And if you do, I'm sure everyone, we're all patients in some way or another. How many of you have gone on to join a support group for that condition? How many of you have Google alerts for news on your condition? How many of you are participating in clinical trials? How many of you have joined a registry? And I am almost positive that many of you would have identified with having something chronic, but many of you wouldn't have done the rest that's on that slide in terms of joining support groups, etc. And the reason is, you know, you ask yourself, well, why? Why haven't you? Why is it different in the rare disease space? And the difference comes down to the data. When you've got access to a ton of information, it becomes irrelevant. We know that you can jump on Google and you can get a whole variety of things. We're not spending time in libraries anymore. You know, your kids come home with a project, you know, you've got access to information. When you are sitting in a space where access to information is so pragmatic, it's completely, you know, very, very difficult to find, identifying accurate information, etc. It changes the perception and the way in which you engage with information. And I think that that's the one thing that we need to realize, is that in the rare disease space, we have to do things a little bit differently. So this is why you've got patients that are engaging support groups. You've got patients that are deriving their own diagnosis. You've got patients that are really involved in research and drug development. It's because we have to be, because that information is not readily available. The people that you would routinely go to in healthcare to provide you with that information, being your clinicians, etc., are not necessarily always more aware or knowledgeable on the topic than you are as the patient. But this is twofold as well. It comes down to people being able to participate in research, being able to participate in, you know, deriving how this data is used, how it's shared, etc., etc. So it comes up with a little bit of the, and, you know, this is a really interesting quote, that war is 90% information. And I think the war on rare diseases rings true. And I think that maybe this is why we sit in a position at the moment where we are battling so much in terms of accessing, you know, winning that war, is because of the lack of information and the lack of ability to be able to engage appropriately with one another on a lot of these issues. So I have saw a hand shot up, and I'm hoping it's not, I'm hoping that the slides are still going. So I just wanted to touch on three quick areas where I think that this becomes quite significant. One is patient registries. So patient registries really help us with improving disease understanding and awareness, enhancing patients' education and empowerment, facilitating research and clinical trials, driving policy change and resource allocations, and also essentially promoting collaboration and knowledge sharing. And I think that this is the one place for collaboration that Africa has, you know, that there's so much work that we can do together. These registries don't always need to be sexy. They don't always need to be top of the range, but we got to start accounting for our numbers somewhere. And if we don't, we keep going back to this issue where we're not deemed to be a priority. The second issue is around clinical trials. And this is my frustration all the time when engaging with pharma, is that one of their big frustrations overseas is that they can't develop new drugs because they don't have patients who are treatment naive. So you come down to an issue in terms of drug development where you've got such a massive issue in terms of finding new patients. And as a result, our clinical trials don't move forward, and it takes them forever to get them off the ground, etc. And I'm going, in Africa, we're sitting with like 99% of our patient population who are treatment naive. We've not had access to any form of intervention. You know, we're a gold mine when it comes to clinical trials, but there's this perception that we're not able to do them correctly. And I think it's something we really need to rectify. Clinical trials help us improve understanding. It accelerates research. Again, it helps with patients' empowerment. It gives them the ability to be able to put information into the system around what it is that they are expecting to get out. It assists with regulatory decisions in terms of prioritization, and also helps with collaboration and awareness. And then the last thing is with regards to real world data. And I think so many of us sit in a position where, you know, real world data it's like this far removed in the rare disease space. But in actual fact, that real world data is really what we should be focusing on, because that's what drives the changes we need to see. If you can get these things right in a rare disease environment, it will automatically have positive outcomes to other disease areas and other healthcare systems, simply because of the fact that rare disease patients are so complex to treat. So understanding longitudinal data analysis, patient-reported outcomes. You know, when we speak about drug efficacy, accessing diagnostics, etc., we as people working in this space try to develop systems that we think are suitable for us. And then when you actually go and engage with the patient, you realize that that's not what they're looking for. I remember running a focus group for spinal muscular atrophy, and I asked the question, what would accessing treatment mean for you as the parents of these children who are impacted by SMA? And, you know, a whole bunch of answers came forth. And the one dad said, for me, it would mean giving my daughter back the dignity, because she would be able to go to the bathroom on her own. And I thought to myself, you know, if that doesn't drive change, then really nothing will. We think patients want fancy treatments because it can give them A, B, and C. But actually, when you engage with them, you understand that the needs are sometimes just so simple. And if you have that understanding, it makes it a lot easier to engage with. We don't actually have to change everything. We can start changing the small things, and that will automatically have a great response. And then obviously things like safety monitoring and risk assessment, understanding what these patients are going through, understanding how the treatments and interventions impact them from a day-to-day basis, and also understanding the ethical considerations. Ethical considerations in drug development, in data, are so imperative. And I think we've had a lot of lessons in the African space around that. So yes, I'm really looking forward to the panel discussion. I'm looking forward to engaging on some of these topics. I hope I didn't race too quickly, and yeah, we're here for any questions.
Thank you so much, Kaylee. We did have a hand raised, Melissa Nell. I'm not sure if you would like to ask your question. I can allow you to talk.
Can you hear me?
We can.
Thanks. I just wanted to ask from just the experience that others have had in terms of taking consent. So my lab is involved in the genetic diagnosis of neuromuscular disorders, and we, as a bioinformatics lab, we are sort of very interested in what we can do with the patient's data in terms of advancing tools, methods development, things like using pan-gene and graph references, you know, all aspects that we think are really important and when you're studying underrepresented population groups. So things like, you know, aggregating the data to get allele frequencies, as I said, constructing population reference graphs to use an analysis pipeline that might address reference genome bias and aspects like that. And these, I guess, would all fall under sort of a secondary use of the data, aside from the, you know, the genetic diagnosis. And I'm just interested to hear from others whether you take consent for these sort of uses of the data, which I think are really important for rare diseases. Another aspect is also sharing variant interpretations in ClinVar, whether this is something that people consent for specifically or whether they do it. Thanks.
Thank you. Prof. Lemaka, would you like to start off with your comment? And then we can invite the rest.
Yeah, and thank you very much, Melissa. Happy to see you here. And I'm happy to see all my co-panelists and Kelly. It has been a long time. Okay, so allow me to address that question in two different settings. The first one is when we are administering a consent, just that stage, when we are administering a consent, from experience, what I see is that we are discussing with people with two different groups. The first group is the group of people who know a little bit of genetics. They have a little bit of literacy in general. It may not be deep literacy on genetics, but they have a certain level of literacy, education, and they are seeking, sorry, they are not seeking, but we are actually engaging. We are doing the movement, going toward them, trying to explain to them that their beloved one might need a form of genetic testing for the care to be tailored to this, the diagnosis. When we do this movement to people, they have a little bit of knowledge, but they are not making the first move. I have the feeling that we are getting the proper informed consent. It's meaning that not only are we bringing this information about the test, but they are agreeing because they believe that, yeah, they have been convinced that this is a way to go. This is something that is important for their children. And then on the other end, the other group of or community of families we are dealing with is families that are coming out of desperation because of the diagnosis odyssey. Karen projected that slide showing the diagnosis odyssey, how it's long, how it's costly, how it's labor intensive. We have those families that are coming out of desperation. In many of those families, we don't get the proper informed consent. You may ask them to sign anything they would sign out of desperation. They even don't take time to understand that providing consent for data sharing has nothing to do with the care that would be provided to the child. They have this feeling that if they don't provide the full consent, check everything, they might not get the appropriate care they would expect from the research or for the diagnostic lab. Two different categories of community. For the second, for us, it's not the appropriate category to offer testing to because of the bias consent that is obvious. Then what are we asking people to consent? Yes, as a big advocate, as you know, Melissa, for data sharing, we have in our consent the reuse consent. That is broken into two different domains: the reuse of data, and then we have the reuse of sample. In each of those categories, we also have two subcategories. The first reuse is to be reused for other similar researchers, and then to be reused for all other researchers. So we really pay attention to break that into two, because some families might feel more comfortable to allow us to reuse for similar researchers, but others would go for the say, okay, you can use this for all researchers. So for us knowing how important that is, during the discussion, we show that to the families. If we are able to reach the diagnosis in our patient, is because other people have allowed us to have access to their data, to have access to the findings. This is a critical resource that would allow us to reach a diagnosis in your beloved And your information also might help other families to get the diagnosis. They understand the value of sharing the data in this way, but they are given the opportunity to share in 2 different categories. So that reuse implies the sharing also. We can reuse those data for research and deposition anonymously. We really insist on that. Nobody will be able to recognize you in the public resources. We don't say CleanVar, we don't say no man, because then you go into specifics, it gets more complicated. Anonymously in public resources. And thus far, the only place where we don't have the full consent is the photographs, because we also ask the same thing for photographs. You don't have 100% of consent for that. But for the rest, when we say it's important for your family, for other families, it's important to share those informations. And we share this anonymously. We kind of get 100% of consent that's far. But as I mentioned before, the person consenting, the counselor or the clinician consenting, need to vet the consent you are receiving. Is it an informed consent, or is it a consent out of desperation? This is a key step.
Thanks, Prof. And I just as a genetic counselor, I think I can provide some insight in that, Melissa. The one thing that's important, at least from our experience, is that the informed consent documentation, if not translated into the patient's language, needs to be explained to the patient sometimes in a language that they can understand. So even if they're signing documents, let's say, that are written in English, having someone there to be able to explain it to them in a manner that they're going to be able to understand makes a significant difference, because it means that they know what they're agreeing to do. I'm not sure if any of our other panelists want to add anything.
Yeah, I just want to reiterate, you know, from our perspective, I think from the patient side as well, I think it's imperative to understand that, and Prof. Mes says it well, in that when you come into the space relatively desperate, you're often seeking a diagnosis. I mean, you're prepared to do anything anyone asks you to do to find answers. And I think so. Understanding that that is where patients are coming from is imperative. Realizing that that is why they're in front of you is important, but also giving them the opportunity to take time to consider. I feel like those situations often, and this is from my own personal experience, you get put into a position where you've now got someone in front of you that's engaging with you on the consent, and the impression is that you have to make a decision there and then. Without really having the opportunity to walk away and, you know, go consider it. And I think most importantly as well is giving them information in terms of where they can change, increase or expand or reduce the consent that has been provided at a later stage. I've spoken to numerous patients within our space, and patients have signed up for a bunch of research projects, data projects, etc., etc., in that time of desperation. And now 10, 15 years later, you actually have no contact with those people, and you have no idea how to go and change or withdraw that consent at this point. So I think that that's an important thing to consider as well.
So having this ongoing thing. And I suppose that Dr. Yakue, the issue that you raised about a patient sort of being recruited into a study and then going through this process of trying to see a whole bunch of doctors and ending up back in your department, it does say a lot, I suppose, about the desperation of the patients, which has been alluded to, but also the fact that if the information is communicated in a very high stress or like an urgency kind of environment, patients tend to leave that environment and don't think about it too much afterwards. And so at the moment, their consent is informed because they understand, but perhaps don't engage with it much in the long run and then end up being surprised.
Yeah, you're definitely right. I think the I already mentioned one of the challenges, but the fact is that most of these patients come to the clinic of seeking treatment instead of, you know, it's our view that to understand. We need to understand what is going on before we can provide any treatment. But when they are there, and when they are talking about the informed consent, we are talking about many things in the clinics, but they are definitely thinking of how to cure their disease, right? Correct. So, and then at the end of the day, if you say, okay, we will spend investigating the case, spend like 1 year or several months before we can have a conclusion on, say, in this family or you and your family members, you have this particular disease. So this is something really challenging in the clinical setting, because we are not researchers, we are care providers. So they came to the clinic not for research, but they came to seek for care. So in this context, sometimes what we are talking about and what they are expecting to understand is there is shift on that. So we need to make sure. I definitely agree on what you mentioned, and this is some of the challenges we see in the clinic.
Yeah, I think we don't have many options. You know, you don't always get to engage with the patient many times over a period of time, and so you want to do as much as you can in the time frame that you have. But I share that sentiment that many of our patients come and thinking that they've been sent to genetics, and a lot of them, I mean, Kelly, you mentioned that a lot of patients seek out, you know, support, but truthfully, a lot of our patients get sent to us and actually have no idea why they're being sent to genetics. And so, you know, they're hoping that someone is going to be able to find some type of answers for them. And often that ends up being part of a research project that involves months or years of investigation before we can get an answer. The one thing I wanted to, yes, Kelly.
No, I wanted to say, like, I want to ask a question to you as the genetic counselor. What can we do to change that so that patients, you know, if you are better prepped for an appointment, you can utilize the time and space better. Yeah. If you know what you're walking into, and you know, if someone says to you, going for an angiogram, this is what to expect, this is your recovery time, and why is it that when we're referring to genetic services that information sharing doesn't happen? And what can we do as a collective to improve that, so that the time utilized, understanding that it is so scarce and resources are so so scarce, what can we do to ensure that when patients are there, then they do have a good understanding?
Look, I think there's a couple of things, and some of our presenters have already touched on it, is improving genetic literacy, firstly amongst the medical fraternity, so the provider population, because a lot of, at least from my experience, a lot of the patients get sent to us and the doctors go, well, you're going to genetics and they'll explain it to you. Like, we don't really know what's going to happen. And so they've kind of done what they can do, and they've reached a point where they have exhausted their efforts, and the next logical step, if they know about genetics, is that the patient needs to go to genetics. So I think firstly it's educating the provider population on the availability of the service, but also what the service entails. And then largely it's educating the public on genetic literacy. I think a lot of the strategies raised were very important and did include, you know, launching better training and understanding amongst the provider population. But I do think that basic genetic literacy, look, I think we've got issues with basic literacy in general in many countries in Africa. But I think that improving genetic literacy as a whole will help empower patients to be able to come to those sessions and to ask appropriate questions and to make use of their time how they see fit.
Yeah, can I compliment on that? Okay, so there's a debate actually in the US on genomic medicine, how to improve genomic medicine in the US. One of the things that have been noticed is there's a need to increase the workforce. Okay, if the genomic medicine need to be practiced broadly in the US, there's a need. You can imagine a highly developed country, they say, we don't have enough people. We don't have genetic counselors. We don't have clinical geneticists. We don't have lab geneticists. We need to train more of these people. The reason behind is if a child is lucky, he might be able to be seen once by a geneticist, but all the rest of the life with the GP, the pediatrician, and so on, the nurses. So in Africa, we don't need to go that path. We can start by training all the people that are going to get in touch or in contact with patients, nurses, GPs, and the pediatricians. All these people need to be empowered for the genetics. Then the message the patient or the family will be receiving from the moment they enter the health system would be consistent, would be the same message. So there will be no disconnect between the information they are receiving at the basic level of the community, where they might be a return to the alternative care, but they will be receiving the exact same message that will lead them to the path so that they are much more quickly in contact with the genetic service, and they are coming for the appropriate reasons. They know why they have been referred to that and what they can expect. So there's really a need for us to train. As Monica mentioned, it's not only the families, it's also, first we need to start by all this medical community. We need to empower them. And when it comes to the families, I think we need to tailor the message with the culture of people, really convey the message in a way that would match with the culture of people. I believe that Africa is the best place for sharing, for data sharing. That was the question from Melissa, for engaging with the community, because we do that every time. You go to the church, how many people you see sharing personal stories during the testimony in church? You see this in Africa. You don't see this in Europe. People are so open talking about this in church, but they are not talking about this in the hospital. There's a problem. We are not adapting to the culture. If people are able to share so personal information there, there's a way we can do this in the hospital. Just learn from what is happening in our community. We should be able to do this.
I suppose it does raise the concern that was raised earlier about any negative repercussions from sharing that information, you know, like insurance and having those kinds of barriers. Prof, what is your take on that? Do you think that that's why it's impacting the sharing of information outside of those more cultural environments?
There are different aspects in that. How many countries in Africa today have insurance system that can reimburse the care? I would, out of my mind, count 3 to 4. So it's not really a general problem to Africa as a broad continent. It's very specific, and I think that can be addressed in the context of those specific countries. The thing that is broader is other people benefiting from those data, developing, for instance, medical products, pharmaceutical companies, and so on, developing those drugs. It's an important concern, and the way we can address that is by defining what is the benefit for patients and see the sharing associated with the benefit sharing. So it should be a two ways. We are sharing our data with the broader community. This is what we are drawing from the global community. Clearly define the benefit for the patients. The benefit might just be the diagnosis, the care that will be tailored to that, but the benefit can also be for the patient next door. The benefit may be for the medication to be developed that would save hundreds or thousands of lives. We need really to develop that or to convey this message by always associating the fact that you are giving to what you are drawing, not limiting this to the diagnosis or to the care to your patients, but this is the good you would be doing to our community, to your cousin who might be in the US. So And there's another level that requires the intervention of government for protecting research participants. What is the potential benefit from this research, and how this can be shared back with the research participants? I think we shouldn't be doing this as medical doctors or researchers at our own. We need structure, like you have the new law in South Africa around research. We need these types of laws in many African countries, really setting the stage on all those aspects, including sharing data with the broader community, but also drawing benefits for the local population. We are lacking that at the moment.
And I suppose having well-established agendas with patients, so them knowing why they're coming to us or coming to see genetics and what they can expect out of it, but then us also being very transparent and explaining what can and can't be achieved as the time progresses. The one thing I wanted to touch on, Kelly, maybe you can also comment on this, is the inclusion of patients. Because for a long time, I think a lot of research has happened around patients and what we perceive to be beneficial for patients. And it looks like there's been a change to some extent to start inquiring with patients about what they need, what values are important, and what is beneficial to come out of research from their perspective. So, Kelly, I know that there's a lot of research projects that are now taking patient voices on board, which is very promising. I'm not sure if you'd like to touch on that.
So I think that there's a lot of work to be done from our perspective as patient advocacy groups on as a like a little example. Ahead, we've obviously just hosted our rare disease conference that took place, and we wanted to encourage patients to come and participate and give, speak at these meetings, but they are completely overwhelmed with being in the presence of professors, academia, clinicians, policymakers, etc., that they feel that they couldn't, it's not an appropriate forum for them. So we did a basic YouTube video where we explained to them how to write an abstract, what you can include in a presentation, how to put your story forward. And it was so well received. So I think that there's a lot that needs to be done in terms of empowering patients for them to actually realize that they've got lay expertise and that they can participate. But I also think work needs to be done in researchers realizing their vulnerability in that regard. So the way in which you engage with them, the way in which questions are asked needs to be done in a patient-centric way. I feel like if you look at research overviews and you analyze what the research project is about, etc., the brief, so to speak, it's written in an academic way, understanding why, because you guys are coming from academia. But it's intimidating for patients. Patients read through that and they're like, I don't know what they're asking of me. I'm unsure how I can participate. Can't even pronounce the words that they're mentioning. Is this even for me? So I think it goes both ways. We need to do some work in terms of getting them to realize that they've got a big part to play and that they can and that they add massive value, and giving them the ability to do that. But also, I think, as we spoke about genetic literacy, I think healthcare literacy needs to develop as well, and we need to develop patient-centric material. If we're wanting to engage with patients, we need to change how we get information back from them so they don't feel intimidated to participate.
Thanks, Kelly. I think that's very important. Being able to allow them to understand so that they can add valuable contributions. The other thing I wanted to touch on is, and it's something that was raised a couple of times, Dr. Karen, I'm not sure if you'd like to address this, but was the issue of cultural beliefs. And in Africa, it's something that we are very familiar with and something that we engage with in many aspects of healthcare and medicine. But the cultural beliefs have persisted and they will continue to persist. And I believe that there is sort of a push to rather integrate them into healthcare rather than dismissing them, and seeing how they can both be true, sort of running side by side with each other without impacting the benefit that the patient receives at the end of the day. So how have we dealt with cultural issues in the realm of rare diseases and rare disease research?
Yeah, thank you, Melissa, for giving me the opportunity to speak about these cultural beliefs. Actually, cultural beliefs have always been in our community and will always be there. And normally, I think we should see this cultural explanation of the rare condition just like a roadmap, where we are adding pieces to help people understand what is going on with them and cope with the different conditions that they are having. So I think that is what I can say.
Okay, so it's providing more context.
Monica?
Add something.
Yeah, Abdullah, you can go first, please.
Okay, yeah, I just want to add something on just what Karen said. I think it's something that would be the cultural belief is really in most African countries. And if I take an example of one particular ethnic group in Mali, where I am from, you know, if something bad happened to the family or to somebody in the family, so there should be a basic explanation. They think if something bad happened, it's caused by something supernatural or mystic event. So in seeking of this understanding, so to convince those people to understand this, some of these things, they have a medical basis. We should be talking about the evidence, the scientific evidence of this information, to let them know that this thing you think is caused by a mystic event or any supernatural cause is really has been proven somewhere else, and is caused by this particular causes, which is not supernatural or something like that. So this is, I think, one of the way we should go.
Yeah. What I would like to add is that whatever the level of education of the parent is, they carry this. Even if they are university professors, they have this in them, the mystical belief.
Yeah.
This is the likely explanation for all the families that we are receiving. Second, the mother is also considered as being the responsible of the disease in the family. So when you integrate that there's mystical belief behind, the mother is considered as being the likely cause. And whatever the level education of the person I'm talking to is, there's this component is, then it's obvious that you need to address this. We have in our constant process, the last part where we address this after asking the family, do you have any question to us? And then we go on into this. We know that you have this. We know that you have heard that it could be mystical. We know that you have probably seen people, but you need to know that we are not doing mystic here. We are medical doctor, because if you believe that there is God somewhere, we have been given this chance by God to become doctors. And there's no, it's not random that you are here. If you believe that there is a mystical power, there's God behind, it's God that chose for us to be here, sitting and talking to you today. It's all in the plan of God, this discussion that we are having. And the diagnosis that we have provided today is not a mystical diagnosis, it's coming from the machines. These are not the mystical machines, which means that the disease of your family, it's a biological problem, nothing to do with this. So if you follow the biological process we want to put you through, there might be some positive outcome. So we never let the family go without addressing this. And this is also the part where you will see the tears coming out.
Yeah, because I think a lot of patients engage with cultural medicine and traditional medicine before even resorting to coming to a hospital. The hospital ends up being their last resort. So yeah, I think it, and obviously as a genetic counselor, we know that it does alleviate a lot of blame and shame once they do have a diagnosis that Okay, we have a raised hand.
Hi, Monica. Thank you very much for the discussions. However, we have like a poll designed for the participants so that they are able to relate with the discussions and how they are feeling about what it has been discussed. So can we share it before they exit the webinar?
You can.
Thank you.
And I'm just, as you share it, I'm gonna start wrapping up. I think
Okay.
that there has been a lot of important information raised, and it seems to me, at least from watching all the presentations, that a lot of the issues that are raised, it doesn't matter what the condition is, it doesn't matter where in Africa it's based, a lot of the issues are very common and overlap. And so it's something that we need to continue talking about and putting our heads together, because the issues that are raised in one part of the country or one part of the continent is going to be very similar to issues raised in another part. And so it's not about working in silos, but rather about combining our resources for the benefit of the patients, and not just for current generations, but future generations as well. So people can start answering the poll. I am going to wrap up and just say that I want to thank all of our panelists as well as the attendees for making it to the Science and Society Cafe and for your contributions. And many thanks to the NIH for funding this PUBGEM-Africa project. We hope in the spirit of Harambee that you would join us for future PUBGEM-Africa Science and Society Cafes. And the next one is on the 23rd of May, and it's on the topic of hereditary deafness, a model for precision medicine in African settings, testing, counseling, and ethical considerations. So please look out on the social media channels or sign up to the mailing list for more information. And I want to thank you all for attending, and please stay well.
Thank you.
Thank you so much.
Monica. Abdullah, Karen.
Yeah, Prof.
Yeah, Prof. See you.
See you.
Bye.
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 I know we still have some of our attendees answering, and we will stay here until you've had a chance to answer.
Okay.
I do think that these ethical guidelines, particularly the ones that have been more recently published, should be more easily accessible, just looking at the poll. So it's definitely something we could work on.
Okay, seems like everyone participated in the poll, and I'm going to end it and end the webinar.
Perfect. Thank you so much.
Thank you very much.
Bye-bye.